start, but now it's already 7 o'clock. I think we should start, and we know the weather challenge that we're going through. With that, I think warm welcome. I think good evening to all of you, distinguished guests and experts. Warm welcome to the master class on navigating the future. Spotlight on advancement in liver disease. On behalf of Roche Diagnostics India and Roche Diagnostic APAC Asia Pacific team, I extend my sincere gratitude for your presence here today for this insightful session, masterclass. Particularly, is a spotlight on the disease, the topic that really immense. Important from a global perspective and from India perspective as well. When we refer viral hepatitis, it's really as a silent epidemic, and India contributes almost 11% of global disease burden as per the WHO 2022 data. But equally important, like what number of cases that we actually experiencing here in India is almost, if you see like 35.3 million cases, and out of those 5.5 million cases, actually the people living with chronic hepatitis C infection. And I think that's where the challenge all about is how best the modalities from a diagnostic perspective, from a screening perspective, from a diagnostic perspective, and equally important when we address these two challenges, how we can really triage these patients to the effective treatment. We know that there is a curative treatment available, but before that, the important steps are mainly into the diagnostic space. And I think very important, like those patients really. What number usually says like 20% those diagnostic receiving treatment, but actually not getting the treatment at all. And that's where how best we can implement the newer modalities available for in front of us, and how best we can implement it. The second topic for today's masterclass is more about the hepatocellular carcinoma, primary liver cancer. I think that also has really a big threat for us when it comes to diagnosis, because most of the patients, though really going through this, it's really in the early stage, really not symptomatic at all. And I think that's where, and also the etiology is also shifting, really like from NAFL, from NASH and other factors that really contributing significantly in overall SCC cases. So the major challenge, like in early stage, where the patient more or less asymptomatic, how best we can shift the needle from screening to the surveillance. And I think the experts today during the couple of sessions, and then the panel discussion will more deep dive into all those aspects about how best we can really shift the needle from screening to the surveillance, particularly those patients who are at risk of development of SCC. So I think with that, all the unmet medical need, I think Roche Diagnostics really work upon bringing the innovative solutions in this space. One is definitely from a chronic hepatitis C infection, that is a dual antigen antibody test, that is what we call Alexis HCV-DO test, and equally about important to really have the surveillance, most effective, efficient surveillance, that is GAT scoring, or using the PIVCA2 and AFP and other age and gender factor. That actually help us getting those very important informations to have a effective treatment. So it's all about it's discussing all those leveraging cutting edge technology, diagnosis, discuss brainstorm on the strategy of how best we can adopt this new cutting edge technology in our current medical practice. It's all about really brainstorming on how best we can enhance the screening and early diagnosis of to really identify infected individual, how really we strengthen the link between the diagnosis and the treatment, right, ensuring access to the curative therapies for all. And also equally like how best in Indian context, right, how we can adopt the SCC surveillance for at-risk population. So we have our esteemed speakers along with our distinguished panelists to really elaborate on these critical topics. We have enough time for Q&A as well. I think keep your questions ready. I think we'll discuss at length each of all the queries that you have or questions you have. So keep your questions ready. And once again, without further ado, once again I'll welcome all of you for today's masterclass. And I think let's start today's sessions immediately. I think welcome again. And on that note, let me take this opportunity to introduce our first speaker, Dr. Tawesak Tanwandee. He's the professor of gastroenterology, Department of Medicine, Siriraj Hospital, Mahidol University, Thailand. He's coming all the way from Thailand to India to share his experiences on the topics that I just mentioned. He's currently a steering member and past president of Asia Pacific Association for the Study of the Liver, (FSL), in year 2000. He is currently a committee member and past president of Thai Association for the Study of the Liver. He is the president-elect of the Gastroenterological Association of Thailand. He received MD with first class honor, gold medal, and received the Thai Board of Internal Medicine Gastroenterology. He also spent 2 years as a research fellow at Department of Molecular Virology at Baylor College of Medicine, Houston, Texas. Professor Tanwandee is currently member of various organizations I just mentioned, also member of American Association for the Study of the Liver Diseases, American Gastroenterological Association, and European Association for the Study of the Liver. His major research interest lies in the treatment of chronic hepatitis B and C, hepatocellular carcinoma, and cost effectiveness of treating hepatitis B and C. So we welcome you, Dr. Tanwandee, for your talk on accelerating SCV elimination, focus on dual antigen antibody test. Stage is yours, sir, Doctor.
Thank you, Sandeep. Thank you for having me. Thank you, Roche India, for the invitation to be here in Delhi. So, what we're going to do uh, this evening, going to talk about what can we do for accelerating the Hep C uh, Hep C elimination by focusing on the concepts of dual antigen antibody testing. Here's my disclosure. So we all know that the WHO goal for eliminating hepatitis virus, what hepatitis B and C and even D by 2030, got to look at whether we can reduce infection by 90% and reduce the liver-related death by 65%. But what we have done so far is far behind this goal. So this got to be uh, all over the world. Now, when we look at in different WHO region, Thailand and India, we are in the same WHO region, in the Southeast Asian region. So you can say that in African region and Southeast Asian region, we are far behind the rest of the world in terms of diagnosing and treatment of chronic hepatitis C virus. So only 5% in our region. So the key cascade for the treatment of chronic hepatitis C, we all know this is the chronic viral infection that can be safely called killed, the only virus that can be killed in our human body. So, but the cascade of kill is far behind, and initiating the cascade of kill is the testing. Without testing and knowing the status of hepatitis C, the patient cannot be treated. So this is the big initiation to test it. And once the test positive, then you can go for the further step for the treatment. But even in the situation, for example, in the US, you see that among the patient who have hepatitis C, just about 50% know the status of hepatitis C, and among these, just about 50% go for the Hep C testing for the confirmation, and just about one third of the whole population get prescription or treatment. You can see in every step there are going to be almost 50% drop out or lost to follow up because all of these people, they are mostly asymptomatic unless it's a patient with advanced liver disease, but mostly they're going to be asymptomatic. So they don't, even they know their status, they don't aware the serious of their status. Now, the situation globally, we have done for injection safety. We're now using the disposable syringes, needles. We have screened blood donor. But in terms of harm reduction to prevent new infection, in terms of testing and the treatment, we are far behind the target. So there are more work to be done to achieve this target, even after 2030. So let's have a look at difference between acute infection on the left and chronic infection. In acute infection of hepatitis C, you will see that the presence of RNA as well as the antigen almost simultaneously a few weeks after infection, and this is even before can be detected by detecting RNA or antigen. The antigen is the protein part of the RNA. So when we lysis the RNA, the antigen will be exposed and then we can capture the antigen. So the antigen represents RNA. So this test can be surrogate for RNA. And then a few months after acute infection, a few months after acute infection, then antibody against these protein going to be positive. So antibody positive, anti-CV positive. Then for chronic infection, for those who got acute infection, some will spontaneously resolve, but most of them will continue to chronic infection. In this chronic infection, there could be the presence of both RNA antigen as well as anti-CV positive. So the anti-CV could be the antibody against the protein produced from Hep C RNA. So this is diagnostic markers of disease stage. So in very early stage and acute hepatitis C, so you will see that antibodies remains undetectable. So it takes several weeks or a few months to be positive. So in late acute or in chronic infection. So presence of anti-CV can be the marker for active infection or cure or past infection after spontaneous clearance. For the RNA or antigen, one, it is positive. Whether RNA or antigen, it represents viremic Hep C. So you can use RNA or antigen as a part of confirmation for viremic Hep C. For the symptom, even in acute infection, Hep C has just less than 10% will be symptomatic, especially icteric hepatitis. So the symptom cannot reliable. Now, what about the Hep C antigen test? So this could be surrogate marker for RNA. So those days before 2016, the use of Hep C antigen got to be as part of the confirmation for Hep C RNA, where in the situation where RNA may be not available or RNA is more expensive, the Hep C antigen got to be another surrogate marker. But the last EASL guideline uh, on 2020, the core antigen, Hep C core antigen is replaced or can be used interchangeable between antigen and RNA testing. Now, what about hepatitis C dual antigen antibody testing? So this is the test that introduced both detection for antigen and antibody in the same reaction tube. So for antigen, they gotta have synthetic anti-CV to capture antigen and then bind with biotinolate probe. And for antibody, it's the same as antibody testing. So this reaction occur in the same tubes, and the report got to be ready within less than 30 minutes. So for antigen, we need 9 minutes to lyse the cells to expose the protein, and for antibody, we don't need the lysis. So the report for Hep C antigen antibody testing got to be separately or combined. The separate result can have core antigen positive or reactive or non-reactive, antibody reactive or non-reactive, and then combine. So the combine, that means positive of either or both antigen or antibody. So the sensitivity when I talk later going to be the combined result of either core antigen and anti-CV. So the interpretation for the use of dual antigen antibody testing, this is according to the latest, either the last guideline for treatment of chronic hepatitis C. So if dual antigen testing negative, you don't have to do anything. This patient can be discharged, so they don't have any current or past infection. In case of antigen or antibody positive, you need to look into detail. So if antigen positive, so just pay attention on the antigen. So if the antigen positive, whether antibody positive or negative, that means viremic. So in case of both positive, that in the situation where chronic hepatitis C, where most of us face with the patient with chronic hepatitis C. But in some cases where antigen positive but antibody negative, this is the situation in acute hepatitis C where the antibody is still undetectable. So these people can go for the treatment without RNA confirmation. I'll talk later on the positive predictive value of the antigen. So for those with antibody positive but antigen non-reactive, so in this situation, you need to separate between past infection or low current infection with low viral load that cannot be detected by core antigen. So in this situation, Hep C RNA needs to be confirmed. So if RNA negative, that's going to be past infection, and if RNA positive, then they can link to the treatment. So now, in the process of hepatitis C infection, in acute infection, I told you earlier that the presence of RNA and antigen usually occur almost the same period of time. So antigen present just less than 1 day after the positivities of RNA. And then uh, a few months later, the positivities of Hep C antibody. So then if you screen the patient in the situation, especially in high-risk population with anti-CV alone, so you miss this period. So this period that where only antigen going to be positive. So then you miss this patient that can be transmissible to the others by not having treated. In terms of the times of positivity, you can see that the dual antigen antibody testing can be positive about 3 weeks before the positivities of anti-CV alone. And this is even earlier than other dual antigen antibody testing where they do not interpret separately. Now, let's have a look at the difference in antigen sensitivity from early infection and chronic or late infection. And this represents early infection where antigen positive but antibody negative. You can see that the antigen can be detected almost 93%. So in acute infection, whereas in late infection, where we are facing the most in chronic infection, the positivities of Hep C core antigen got to be just about 64%. So this 64%, that means this is lower than in acute infection because in this stage, they have anti-CV interfere with the test, so the positivity is lower. But 64%, let's say two-thirds of the patient with chronic viremic Hep C going to be positive by core antigen. When you look at the care cascade that I told you earlier, that in every step of the test, almost 50% going to be lost to follow-up. So, but this test, you can have the result within less than 30 minutes. That means among viremic Hep C, about two-thirds can be treated within the same appointment. So within the same day of the doctor visit, you can give the drug. So with such a wonderful drug, so that means these patients can get cured within the same visit. Now, when we look at the correlation between Hep C antigen and RNA testing, you see moderately correlate because of the interference. It can be very low and can be very high. So this can be the issue. And Hep C antigen that we are talking today is the qualitative test. It's not quantitative like Hep C RNA. So we need to know just positive or negative. But in uh, current practice, we don't need the viral load because we don't care about the amount of viral load. When you look back several years with the PEG in different era, then we might need a viral load to predict the treatment outcome. Now, let me share with you the global study, including more than 26,000 samples. I'm going to share with you some of this cohort. So this is a cohort where they look at the patient in different situations, in acute situation, in chronic situation, in past infection where RNA negative. So you can see that in terms of sensitivities of Hep C duo, 99.6%. So Hep C duo missed only one case set in acute infection where uh, RNA is low and anti-CV is still undetectable. So the sensitivity is very high. Now, different stages in chronic infection and different genotypes, all of them positive for Hep C duo testing. So that means either RNA Hep C positive duo means either antigen positive or antibody positive or both. So all of them positive for Hep C duo testing. Now, in routine sample and in blood donor, also this compare with another dual antigen antibody testing, you can see that again 99.9, almost 100% positive for Hep C dual testing. And what about the positive predictive value? So once you have antigen positive among the 187, all of them positive for RNA. So once you got RNA, the antigen positive, then you don't need to confirm by RNA. You can go straight for the treatment. Now, let's have a look at the clinical data on the real world data. This is the data from Thailand. They look at the anti-CV positive by rapid diagnostic test. So in this situation, uh, 473 RNA positive, and among these 473, 334 core antigen positive. So that comes to about 70% core antigen positive. That means you can skip RNA for these 70% of the patients. So without using RNA, you can use the core antigen antibody testing, one-step test, and then go for the treatment. If the patient were the RNA negative, none of them positive for core antigen. And in comparison, for those with the rapid diagnostic test negative, so again, none of them positive for dual antigen testing. Another study, this is the study to look at uh, it again from Thailand. This is the in HIV clinic. So they look at mono infection and hepatitis C HIV co-infection. You can see that in both mono and co-infection, 87.5% RNA positive. No, among RNA positive, 87.5% core antigen positive. So this is in a real situation in untreated patient in a rural area or in untreated patient in immune compromise. They're going to have very high viral load. So majority of them going to be positive by core antigen testing. And another study, then we moved to another continent, to South Africa, from Cape Town, from Professor Spearman group. So among the use of Hep C duo in the real world practice in her hospital, 62.2% core antigen positive. And when you look at the DNA between core negative and core positive, you'll see that majority is going to be in DNA lower than 4 logs, where the core antigen going to be negative. Where most of the core antigen positive, the levels of the RNA going to be higher than 5 logs. And then you can have the correlation between the levels of RNA and the positivities of the core antigen. So mostly, if you got the patient more than 5 logs of RNA, then more than 70% of them going to be positive for Hep C dual antigen. Another study from France, this is from Lyon, from Professor Fabien Surim's group. So they use Duo for general testing among more than 20,000 routine sample. There are Duo positive about 200, 200 sorry that the slide is fading, 297. And among these, in chronic infection, just draw your attention in the middle, in chronic infection, there are 73 positivities of RNA in chronic infection and 39 positive for core antigen. So in this situation, 53.4% core antigen positive, and positive predictive value always 100%. In these 3 cases, this is represent acute infection where antibody negative but core antigen positive. Another study, this is the last study from Japan, they look at retrospective storage sample. So the overall, the positivity of core antigen by dual antigen antibody test was 55%. But and you can see that the positivity got to be very high after the viral load, more than 5 logs. However, study, there were 44 cases that had RNA below 4 logs, whereas that show that in the same hospital back to 5 years, majority of their patients, more than 70%, had HCV RNA more than 5 logs. Just only 4 cases that had more than less than 4 logs. So that might represent long-term storage of the sample that have low HCV RNA. So if we calculate back using the sensitivities of the Hep C duo by using the viral load that in their hospital, the sensitivity of Hep C duo can be up to 70%. So just to summarize for this part, the Hep C duo, the sensitivity is very high. So the positivity is almost 100%. And specificity also very high, especially in blood donor, in clinical routine sample. And more importantly, the positive predictive values is always 100%. That means once you got Hep C antigen positive, that means viremic. You don't need to confirm by Hep C RNA. This is the result that I could just show you, for example, in my hospital. The upper panel represent antibody positive but antigen negative, and the lower panel represent antigen and antibody positive. So when I took the sample for viral load testing, the upper panel represent low viral load and the lower panel represent high viral load. Actually, we for the lower panel, we don't need RNA confirmation. We can go straight for the treatment. So just to summarize, the values of Hep C duo in various population of interest for hepatitis C infection, especially to scale up the treatment and elimination of chronic hepatitis C in our country, we need simplified testing algorithm. So this could be one step, and then we go for the treatment. We can increase access to confirmatory diagnosis, and this can be useful in high-risk population, even in population where the infection prevalence is high, and this can be used to shorten the window period, especially in the patients who are undergoing surgery, hemodialysis. This is acute exposure in order to not to miss acute infection. So the positivities of antigen or antibody can be the marker that you need to go further for confirmation. And this can be appropriate for screening tests per need, especially in some situation in immune compromise where production of antibody is low, then antigen could be really useful, or to periodic screening for reinfection. For example, hemodialysis patient who on the waiting list for kidney transplantation, for example, maybe we can in our hospital we screen every year to see whether they got reinfection or new infection. So the overview of testing recommendation, as I told you, that for the latest EASL guideline, they use the Hep C antigen interchangeable with Hep C RNA for diagnosis, as well as WHO guideline for the treatment and the diagnosis of chronic hepatitis C. So at the end of the day, you have choices of approaching the patient with chronic hepatitis C. You can go with the classical pathway. So you ask the patient for anti-CB testing. When the test positive, we call the patient for viral load testing. And when the test positive, you recall the patient for getting the drug. Or you, in some situation, you can have reflex testing. It can be lab reflex testing or clinic reflex testing. In the lab reflex testing, they have blood collection to test for anti-CB first. And if anti-CB positive, they can use leftover sample for RNA testing. Or you can have rapid diagnostic test for anti-CB testing that takes just 15 minutes. And then if the test positive, you can ask the patient for another blood draw for RNA confirmation. Or you can go for Hep C duo. In this situation, you, you draw the blood and the patient wait for 30 minutes. Let's say less than an hour before the blood, the sample will reach the lab. So then about 2/3 of the patient can have inviremic hepatitis C. About 2/3 of the patient can have core antigen positive, and this can get treatment within the same visit. And the rest of the patient were antibody positive but core antigen negative, you need to go for RNA confirmation to separate between past infection and chronic infection where viremic is low. So just to summarize, Hep C dual immunoassay. This is dual antigen antibody testing in a single sample. It is beneficial to determine Hep C status, to differentiate, especially to capture acute or viremic. And this result suggests that provide the Hep C duo provide very high sensitivity in detecting chronic infection with high specificity for diagnosis of active infection. So just to remind you that once the core antigen is going to be positive, then RNA always positive. But in case that the antibody positive, but the core antigen undetectable or non-reactive, then you need to confirm to separate past infection and active low viremic. And these two can significantly reduce the cost of using RNA testing. So among viremic, 2/3 can skip RNA testing. So just only 1/3 need RNA confirmation. And then with this single test, this can reduce turnaround time. So you can have to set the result within the same visit. And this can expedite the treatment for the patient. And this can increase the uptake to scale up the treatment in chronic hepatitis C patient in our population. With that, thank you.
Thank you so much, Dr. Tanwandee, for throwing light on the newer innovations that can bring paradigm shift in the HCV diagnosis. Hello, everyone. I'm Sneha Shah, Marketing Manager from Roche Diagnostics. And once again, thank you and welcome you all for your time today. Before I move on and call upon our next speaker, just one request that I had from everyone. We have some chart papers kept on the table with sticky notes. I would urge and I would have a sincere request if you all can put some of your expert opinions with respect to current diagnosis and how newer assays can fit into the algorithm of diagnostics and help in HCV care cascade. So that'll be quite helpful, throughout the session. And with that, yes, I would be very, very happy to call upon our next speaker, Dr. Ashish Kumar, who's the professor and senior consultant of gastroenterology at Sir Gangaram Hospital, New Delhi. He was named as one of the top two scientists in the world by Elsevier and Stanford University. He has received the India International Healthcare Award for being the most promising gastroenterologist of the year 2018 of Delhi. We welcome you, sir, for your talk on addressing unmet needs in HCV, opportunities for dual antigen and antibody test in India. Over to you, sir.
Thank you, Sneha, for that kind introduction, and thank you, Roche, for having me here. Uh, it's a pleasure to be here and talk about uh, this hepatitis C duo assay and all these latest biomarkers which are there. So I would be talking what are the unmet needs in India regarding the hepatitis C. Uh, so as you all know that viral hepatitis is an epidemic which affects lots of people, including children and marginalized population. And 1.3 million people died of viral hepatitis in 2022. So this is still remains a major challenge. Viral hepatitis and tuberculosis are the second leading causes of death, even during the COVID era. After COVID, and hepatitis can affect anyone, but especially it affects those who are underserved population. So going briefly into the basics, so what is hepatitis C? Hepatitis C is a curable infection which can lead to serious liver complications, and the most important thing is that it remains asymptomatic for a very long period, where it can remain there as the asymptomatic viral infection causing chronic hepatitis in these patients, and then it can cause fibrosis of the liver in about 70 to 80% of the patients, and then it can lead to cirrhosis and then decompensated cirrhosis and then even HCC. So 80% of the infected individuals are asymptomatic. That's the most important things. And even those who develop symptoms, the symptoms are very non-specific, like fever, fatigue, loss of appetite. Very rarely, some people, less than 25% patient may have mild jaundice, nausea, or dark urine. And then the outcomes that there could be spontaneous clearance, or it can lead to chronic infection. And then it would require treatment in form of direct acting antiviral agent. And after an acute infection, there is a mean period of 6 to 7 weeks when it can become chronic or lead to some symptoms. So these are the scientists who won the 2020 Nobel Prize for discovery of hepatitis C. So this is a virus where it has a cure. It has a cure which can lead to raised hopes in eradicating hepatitis C. So this is a virus which, when we were in the college days, that time it was discovered, and now we also have a cure and we have a power to eliminate this virus. And the way to eliminate are the drugs which are called as direct acting antiviral agents, and those have dramatically changed the landscape of hepatitis C management. About 10 to 15 years ago, we used to treat these patients with interferon. It was very difficult, and there were so many side effects, and it was difficult to achieve even 50-60% of eradication rate, what we measure as sustained viral response. And now we are with the direct acting antiviral agents, we achieve more than 95 or 98% of SVR rates. And there have been studies. Study was done by Dr. Rakesh Agrawal, where he calculated that it's cost effective. If we use generic HCV drugs, it is cost effective and it saves millions of dollars in these patients. So the future of HCV diagnosis, because we have a finite course of direct active viral treatment, which just requires 1-2 months of therapy, or it can cure 3 months of therapy, and it can cure HCV infection in most cases. So we have a very good treatment available. Now the key challenge is identifying patients who require this treatment. That's the most important thing. And after identification, we need to link them to cure. Okay, so with high efficiency of these drugs which are available, the testing and screening is now the crucial aspect. Before the crucial aspect used to be the achieving cure rates, but now we have very good drugs, so cure rates are not a problem, but detecting these patients and linking them to cure is a major challenge. So as Dr. Tanwandee already mentioned, that the WHO goal is to eliminate hepatitis, both hepatitis B and C. And to achieve that, we need an 80% reduction in new infection and 65% reduction in death by at least 2030. Then only we can achieve a cure. But we are far behind this target. We are somewhere here, and we are still not in that goal. So what are the steps to achieve this elimination? The number one is raising the awareness, like what we are doing now, and developing evidence-based policies. And after raising the awareness, the second important thing is screening these patients whom we encounter. So in India, the HCV elimination strategies, we need to focus on increased testing and linkage to care. So we need to increase the testing in patients who are marginalized, to patients who are immunocompromised, and patients who are blood donors. And in a recent meta-analysis, it was found that prevalence rate in India is up to about 0.85%. It was about 0.44% in pregnant women and blood donors, asymptomatic blood donors. Although these values look small because they are less than 1%, 0.8% in pregnant women, 0.4% in asymptomatic blood donors, higher in the HIV infected patients or HIV, HCV co-infected patients. But because India's population is highest in the world, so it still becomes millions. So the global burden of HCV infections, they are 50, according to 2019 estimate, there are 58 million of people who are living with chronic hepatitis C infection, and still 1.5 million people are getting new infections, and very few of them are able to receive treatment. In India, according to 2022 estimate, 5.5 people are living with HCV, and 140,000 new infections are there every year. So importance of HCV testing is it allows early clinical intervention, and it allows linkage to care. And because if we are able to detect these patients, then we would prevent further disease transmission. And this is very important because unlike hepatitis B, where a very effective vaccine is available, still we don't have any vaccine for hepatitis C. So the only thing remains is to detect these patients and to link them to cure, and so that we can prevent disease transmission, and we can achieve a WHO goal of HCV hepatitis elimination. And according to this estimate, that most persons with HCV are not diagnosed or treated. So globally, only 21% of patients who are having HCV are aware of their HCV status. And even those who are aware of their HCV status, only 62% are receiving the treatment. And what are the barriers to screen HCV individual? So awareness is one of the most important thing. And 8 out of 10 people with hepatitis C do not know their positive status. So we need to find these people who are HCV positive. If we look at the HCV patient journey, so once HCV patient who is infected, once we screen them, many of them gets lost to follow-up. Even after diagnosis, many of those before treatment is given, they are lost to follow-up, and during treatment, many do not complete treatment. So there's a lots of follow-up. If we are able to reduce these loss to follow-up, then we can achieve a meaningful journey towards HCV cure. So what is the traditional two-step method what we routinely follow in India? We do the testing according to anti-HCV test. So we initially screen all patients who come to us with anti-HCV test. Once anti-HCV is positive, and the challenge is that anti-HCV does not differentiate between active infection and or the patients who have past infection. So we need to do a viral load testing. So we write in our prescription to get their HCV RNA test once we find that their anti-HCV is positive, and then the patients takes another couple of weeks to get their HCV RNA. Then there's a bottleneck of cost, and then they come back with the positive results. Then we can offer the treatment. So this can lead to delayed treatment, and this can hinder elimination goals. And Many of these patients do not come back, and then they can continue to transmit these infections among their other people. So, as this diagram was already shown by Dr. Tanwandee, that from timeline of acute infection, various biomarkers that are elevated. So anti-HCV actually becomes positive a bit later than HCV RNA. And here comes the role of antigen testing. So antigen would become positive much earlier than anti-HCV. So there's a window period where if RNA is not done and only anti-HCV is only relied upon, then we would miss a lot of patients during this window period. So this Alex's HCV duo, it is a combination of anti-HCV and HCV core antigen, and this actually is able to detect these patients during this window period also. So if we go by simplified, it actually simplifies the diagnostic algorithm. So if we do this test, which is a combination of antigen and anti-HCV, if both are negative, so HCV duo is negative, we need not go further. If it is positive, then we need to see why it is positive. If it is positive due to HCV antigen, regardless of anti-HCV positivity or negativity, we can directly offer treatment to them. But if only anti-HCV is positive and anti-HCV is antigen is negative, only then these patients would require HCV RNA testing. And then depending, so it will reduce the patients who require HCV testing. So HCV antigen is positive, you can directly go for treatment. If antigen is negative only and antibody is positive, only then you require HCV RNA. So it simplifies. So as soon as the patient comes, instead of getting their anti-HCV testing, you just do this HCV duo testing. This will simplify, and then you can straight away start the treatment. So now, as Dr. Tanwandee showed, that even the EASL guidelines as well as WHO guidelines have mentioned that you can use antigen testing instead of HCV RNA testing for initiating treatment, because it's a good surrogate marker for HCV RNA. And this is the WHO guidelines in detail. You can go through it, and it here mentions that you can actually do antigen testing or HCV RNA test or antigen test. You can do any of them, and then you can start the treatment in these patients. And there have been many studies on Alex's HCV duo immunoassay, which the data has already been presented by Dr. Tanwandee, that it has got very good sensitivity in those patients who are viremic, and all these studies actually say the same thing, that the sensitivity and positive predictive value of this HCV duo is excellent, and you can rely on this for uh, this. Now, who should be tested for HCV infection? The current guidelines recommend testing anyone who has elevated risk. For example, patients who have unexplained chronic liver disease, patients who are hemodialysis patients. One of the important problems in hemodialysis patients is there, because they are immunocompromised and they are repeatedly getting hemodialysis done from the machines. They can get infected with HCV, and because they are immunocompromised, so they would not mount up an anti-HCV. So the only way is either you need to do HCV RNA testing, but here it becomes a very good test. HCV duo can be done. Then patients who have high prevalence population, for example, some areas of Punjab has got high prevalence. Then pregnant women, transfusion recipient, then patients who are MSM patients, and then children of HCV. There are many of these groups where this test can be very useful. So to summarize, ladies and gentlemen, that identifying HCV is the most important step in reducing the global burden of HCV. And screening, we need to link them to care. That means we should avoid any loss to follow up where HCV duo actually can be helpful. Public awareness, like uh, uh, among the lab personals, among the doctors, among the general public, is an important step. And then availability of this test would be a good way to eliminate HCV in these patients. So it's time to act, and then because hepatitis C can't wait. Thank you for your patient hearing.
Thank you so much, Dr. Ashish. So the session is open for question and answers for both the doctors, Dr. Ashish and Dr. Tanwandee, if anybody would have.
Yeah. Good evening, everyone. I'm Seema Bhargav from Gangaram Hospital. My question is to both the speakers. I'm not sure which one of you can actually answer this. I wanted to know that at what level of viremia are we able to detect the antigen core positive in the duo test? Will we miss anyone if it's negative?
Okay. It's going to be complex. So the higher the virus, the more percentage of the patient going to be detected by the core antigen. So mostly, if the virus greater than 5 logs, that's going to be positive by core antigen. But in real world practice, more than 70% of the patients going to have viral load more than 5 logs. And in a real,
Sorry, what is that? Logs.
so 5 log is going to be 100,000 IU.
So that is basically the detection
But
limit.
but it can
Okay.
be detected even in a low situation. But it can be, for example, a few thousand can be positive for core antigen because this could be complex interplay of the antibody in the patient serum. So in some cases, the lower the virus, the lower the positivities of the core antigen, but it's not that non-detected because some cases can be detected even down to 27 IU per mil.
Okay. Thank you. Thank you.
So it can be incorporated in the diagnostic algorithm, but still we will be needing hepatitis viral load to see SVR after the treatment. So, like the message of the flowchart that we do not need HCV RNA, I think is not appropriate. It may.
Do you need HCV viral load for
SVR, yeah.
And it depends. Now, so if you got the software with the SVR almost 100%, 99%, for example, in mass, your guideline include confirmations for SVR, but in reality, we don't know how many of the patient will go for confirmations of SVR. But in that situation, if we think about SVR, we need more sensitive tests. I think in that situation where the patient need to be confirmed SVR, I would prefer RNA testing, which is more sensitive. But this is about detection and initiation of the treatment.
So, going beyond the detection, what about the follow-up of the patient and who is on treatment? Would you like to have a viral load at the beginning and then a viral load thereafter? That is what she was asking.
I was asking, we will be needing a
So
viral
you
load.
mean
Yes.
when we start with the Hep C duo, we need to we don't need the RNA viral
Not
load.
for detection. Once you have put the patient on treatment, you will probably need to know the starting viral load and the. I think Dr. Ashish would be able to answer that.
That was the situation in the past, especially where you during the interferon era, because the response is not that well. So maybe you need viral kinetic to see the reduction of the viral loads. But in in a situation where we have DAA, like I should just mention, so it doesn't depend on the viral load in terms of achieving SVR. It doesn't mean that you got a patient with 10 million viral load as compared with a few thousand of viral load. The percentage of SVR remain the same. So actually, you don't need the quantitative viral load. Actually, if you do viral load, in some situations, qualitative can be as well as the quantitative, because we don't need the numeric of the number of the virus.
So, like sir mentioned that initially viral load was very important for initiating of interferon treatment because it was but nowadays even in current practice, when we do viral load, even if few IU are present, we initiate the treatment. So that same function would be done by antigen. So for SVRs, for looking for SVR, we would need viral load. But at least for initiation of treatment, we would not require viral.
Was not achieved even for after 3 months of DA, so we need to repeat the treatment. So
So that time we would require treatment.
Yes.
So, but for initiation of treatment with this
can
test,
give a-
it becomes simplified. So, for example, if patient comes for surgery and we do anti-HCV as a part of pre-surgical workup, and if anti-HCV is positive, again his surgery gets delayed unless we treat it. So this simplifies the algorithm. So if in the same step we can.
Dr. Ashish, how soon are you going to give us the opportunity to do the test?
I think.
And how soon are you going to make a policy for the hospital? We're from the same hospital. Let's do it.
I had a query or a concern. Uh, if we do the duo test, the antigen, uh, theoretically, we are still going to miss some positive cases because in low viremic loads, this test will be negative, isn't it? That's what you had said. So we will be missing a few of, let's say, 30% or 20% of the cases. Now, if we take our approach, public health screening versus individual patient testing in a clinic. Now, for a public health, this duo test I think is very, very effective, where you are eliminating the use of RNA viral load, which is difficult to get both for cost and logistic issues. But if I'm talking of an individual patient who is coming to my clinic, will you be satisfied if this test is negative because it is not a 100% negative predictive value? So for an individual patient, you will still go for a viral load.
So it will be it tests two things. It tests at anti-HCV and it tests HCV antigen. So it will miss only those patients in whom anti-HCV is also negative and antigen is also negative, but still they have small amount of viremia. Only those patients, because if anti-HCV is positive, then we have to do RNA. So very few patients would be missed because only those in whom antibodies have also not formed and antigen is not there and viral load is low. Only those patients. And of course, like rightly you said, that in a tertiary care setting, maybe the patients who come to us, we would be doing everything. But for public health setting, I think this test would be wonderful.
I think we need to differentiate between analytical sensitivity and clinical sensitivity. Analytical sensitivity of viral load is 10 international units per ml. International of antigen will be about 3 logs or 2 logs less. But clinically, the only difference will be that since if in the early stage, the viral load can be picked up, virus can be picked up earlier, 1 or 2 weeks earlier than the antigen. But 1 month earlier than the antibodies. And then, as it's been pointed out, that for sustained viral suppression, you do need viral load. Then this antigen detection will not work.
This comment and question is to Roche, since it was quite evident that the positioning of this particular kit would be at public health levels, detection levels. So it needs to be, I mean, in terms of cost, positioned much lower than HCV RNA and almost equivalent to anti-HCV testing. So would that be possible? Because only then I think it will be taken up as the first test for screening, where you really want to position it. So, any comments from Roche?
Yes. Yeah. So you're absolutely right. It's almost there. It's definitely much lesser than RNA and a little slightly higher than our anti-HCV, but that's absolutely right.
So, yeah, I think very nice discussion. And so it is very difficult to lay down a single algorithm for SCV because there are different scenarios. So I'm not asking a question. You see, about 5 to 6 years back, I had done a study on long-term hemodialysis patient in 5 hospitals at Pune. So basically what we found was few things. First and foremost, that if as the number of cycles keep on increasing, or the time goes beyond 5 years, then the rise in the infection rates are exponential. Most of them are asymptomatic. That's one. Number two, what happens is that in a dialysis center, because the infectivity is again very high in the percutaneous route, and people who have got a fistula installed, they are much more susceptible to this infection. And thirdly, where the HCV RNA thing will come, that if there is a patient with a very high viral load, this is a very, very potent hospital acquired infection scenario. And not only that, during this time, we also found that number of people were co-infected with HCV as well as with hepatitis B virus. So therefore, in a scenario with long-term hemodialysis, from the prevention of the hospital infection part of it, a high viral load has got a different connotation. But in another scenario, with the quantitative viral load may not be important, but definitely for hemodialysis patient and prevention of hospital-acquired infection, or to see how the thing happens. So I think that will be, we cannot now totally say that SCV quantitative is not important. In this particular case, I think it will be important. That's all. Thank you.
Thank you for sharing the study. In your study, what did you do during the hemodialysis in terms of looking at the preference? So you perform anti-CV testing, and then once anti-CV positive, you go for RNA testing, right?
Yeah. So about even 7 to 8 years back, the standard of HCV diagnosis, as far as screening was concerned, was the HCV antibody.
Okay.
However, when it came down to the SCV infection, because most of these hospitals were government hospitals, so there was the cost of doing these tests also. However, when a SCV are people who are on long-term hemodialysis, the test which was accepted at that point of time was quantitative SCV, because for doing a qualitative first and then going for a quantitative was not cost effective. So at at a interval that was fixed, standardized by the individual units or the hospitals, was around 6 months of time. So every 6 months they were doing a quantitative SCV during that time, and it was found that this was one-stop test. That time antigen was not available. One-stop test which not only gave the SCV positivity, also it gave the viral load, so that the other preventive measures can be taken. Now, in these cases, antibody was not taken into consideration once a person has gone into a long-term hemodialysis.
And actually, in this situation, maybe we can use regular dual antigen antibody testing maybe every year or something to detect not only chronic infection but also acute infection, because in this situation, some cases antibody production can be low, and then you can detect both antigen or antibody in case that antigen positive but antibody negative, then you can pick up new infection as well. Just go back to the dual antigen antibody testing in not in the uh, healthcare setting in order to scale up the treatment uptake, but even in the tertiary care center, if you have the one step of test, even the sensitivity for chronic infection, for positivity of antigen, got to be maybe 2/3 of the viremic chronic hepatitis C. But when you look at in terms of uh, when you look at the cost of the test, it's cheaper. You save for RDA testing, and moreover, you can save indirect cost that you overlook for the patient. They need to travel to the hospital for many times. They need to loss from work, absent from work, and those things should be taken into account as well. So 2/3 of viremic can get treatment in the same visit, then they get the drug. And then I think for those who can pay out of the pocket, they would like to reassure that they get cured. So then you can have SVR12 RNA testing after finishing the drug. And that would be another possibility. For those 2/3 who were antibody positive but antigen negative, we need RNA confirmation to separate between past infection and low viremic.
So I would like to ask the Roche team. Mainly, my question is from a technical and compliance perspective. What is the approval status from NIV for this test? First, second, in our transfusion practices, is there any CDSCO approvals or validations, or um, does this test has a potential to replace nucleic acid testing? And because you have a separate structure of rates where we can charge our patients if we do a net testing, if we do a ELISA testing. So similarly for this test, where do we stand as of now? So that's a question to the Roche team.
And to add to that, when will you make this qualitative test a quantitative test? It'll have much more value then, but this for detection, it is perfect.
Then you leave the report. And you don't turn the color. So it's credibility.
Yeah.
Stick well.
Uh, yeah, just to give a answer on the regulatory status. Just to give a brief on the regular, it's already approved by CDSU office, so it's already available in the Indian market. So it's all gone through the approval processing. It's a CDSU approved. It's already we already have a marketing authorizations to sell here in it.
एसिड को रिप्लेस करेगा कि नहीं ये
both having for that, I think Dr. Deepika would be able to answer it. Would you like to take it or do you want me to?
You can start and then I can continue.
Sorry.
You can start, then I can continue.
So, sir, as far as the NAT test is concerned, thank you, madam. As far as the NAT test is concerned, there are very few, products in serological category which are approved, and they have gone through a very stringent protocol right from the beginning of the development of the test till today. When it comes to NAT screening by nucleic acid testing, there are also very few players, and where the products are approved, we are probably one of them. But thank you for acknowledging that, sir. So far, this product which we are discussing today at HCV Duo is not been processed or approved for HCV screening in blood donations. Blood banks. This is best of my knowledge. I am slightly detached from the product at this moment. I'm into different function, but since it's a subject of interest, I took it. But I would request Dr. Deepika to further it.
So I believe you're asking about the NAT test from the.
Take this one.
Hello, thank you for the question. I believe you're asking about the NAT test in the blood banks, right? Just to bring things into perspective, the NAT test in the blood bank is for detection of multiple viruses. So triple H, HCV, HBV, as well as HIV. Here, what we are talking about is the HCV duo test. It can be used to improve the safety of the blood by improving the serology, which is always welcome. However, all over the world, the gold standard for improving the safety of the blood remains NAT. So this high sensitivity, which is required in a very clean population, which is the blood donor population, who are also screened with the questionnaire, you require a very sensitive test for multiple viruses, and hence NAT will always be there. It is in blood banks who cannot probably do NAT. Improvement in serology is welcome, and that is where the HCV duo would come into the picture. So this is about the NAT test, that it will not get replaced, but HCV duo is a good addition for serology. Now to the other question about the quantitative.
What?
HCV duo in the blood banks. So
regarding blood bank, today itself I read the guidelines because I was looking at comparing CLIA with NAT, and there are papers available saying that CLIA would do the same function as NAT. It's as sensitive as that, and of course much more sensitive than ELISA. And of course, it's also there that they have mentioned ELISA oblique CLIA. So that is already approved. And if the cost is the same as HCV antibodies, then you already have a winner because you are getting two. So it is approved. I can give you the guideline which is available on the net, and today itself I read. And then for RNA NAT, we are talking very easily, but only 2% of blood banks in India have NAT testing. And I have had the worst experience in my life from a person who was dissatisfied with a NAT testing. He made me wait nearly the whole day because our virology lab, so NAT is not something to be played around with. This is an antigen which is two logs less sensitive, but it is an antigen which is stable, which can be easily transported. It can be done everywhere. So look at the ease vis-a-vis NAT, etc.
Thank you, Dr. Ratan. I would quickly like to take the other question from Dr. Seema Bhargav. So, ma'am, you had asked the question about a quantitative antigen and the qualitative. I would try to answer the question and then I would request Dr. Tanwandee and Dr. Ashish to take it over. So, ma'am, as we have seen with the DAAs coming in, the testing for HCV has also evolved. Earlier, you needed viral load, which is the quantitative test, baseline, and later. Now you need a yes and no test. So at baseline, you want to know whether HCV active infection is present or absent. That is it. If it is present, you will treat irrespective of the viral load. At the end of the treatment, again, present or absent, and then you will decide on the second line of treatment of the quantitation. Yes. But if Dr. Tanwandee would like to add anything else,
In terms of
antibody is positive for life. So that is a measure of exposure only. So you would detect if somebody is exposed. Second line is you would like to know whether this person still has the virus, that means the active infection, which is where you need the antigen or the RNA, but you only need the yes or no answer. Irrespective of the viral load, you will treat or retreat.
How long does the antigen persist in the body?
How long does the antigen persist in the body? Yes.
Antigen तो होगा ही होगा.
So, ma'am, the antigen appears.
Active infection, the antigen will be there. Hepatitis B, VC. The antigen is cleared and you get white
Yeah. So, so quickly, yes, the antigen is a true surrogate of the RNA. It appears in the blood, as we have seen, as Dr. Tanwandee had showed the slide, appears within 2 days of the RNA, and it will remain as long as there is replication. So similar to the means not exactly similar, but in Hep B also,
Yes.
the S antigen persistence indicates a chronic infection.
So, have you done any study for seeing this antigen duo test as for the treatment response or the prognostication?
So there is a study not done by Roche, but there is a IIS which Dr. Tanwandee had actually showed the other data of it. They have seen whether this test can be used for SVR. The conclusion of the authors is that in resource limited settings, you can use. There is decent sensitivity. However, we believe that it is not the right indication for use for reasons obviously stated. In DAA therapy, viral load is already going to be low. Then you wouldn't like to test with antigen because negative antigen will not indicate a successful treatment.
This is what I'm saying.
Yes.
Positive predictive value, but we are not very sure about the negative predictive value. That's
Yes. Thank you.
just to wrap up on the quantifications of Hep C antigen, I think you can have Hep C antigen quantification if you do only single test for Hep C antigen. But in Hep C antigen antibody test, it is a complex interplay between the antigen and antibody. It is not directly correlate with the virus as good as single antigen testing. But the good thing for this is going to be one test in single order or in a single tube. So you need to trade off between quantifications and the qualitative. But in reality, the quantitative of Hep C antigen, it doesn't mean anything.
Thank you, please.
any quantitative antigen test.
Isn't that good, like pre-employment screening test? How like it is better than the prevalent test? Hmm.
Because if you because there are authorities here, but if you compare it with any RDT or any available test, this test is far better.
Okay.
Would you like?
Okay, thank you so much for the enthusiastic interaction. It was really insightful. Next, I would like to call upon our next speaker, Dr. Bhaskar Nandi. He is the Director and Head Center for Liver and Digestive Sciences, Sarvodaya Hospital and Research Center in Faridabad. Sir has worked as a gastroenterologist, hepatologist, endoscopist for over 15 years He's a member of INAZIL IAP. He has more than 26 publications in the International Journal of Repute. And Sir will be taking us to the next session, which is clinical utility of PIFCA and GARD in HCC surveillance.
Yeah, thank you for the kind introduction. But there's a small correction in it. I was at Sarvodaya Hospital after leaving army maybe about 4 years back. Currently, I'm at Amrita Institute of Medical Sciences in Faridabad and heading the department over there of gastroenterology and hepatology. Uh, Good evening to all of you. It's a really, I'm thankful to Team Roche for including me in this very important initiative on managing HCV and hepatocellular carcinoma. My role over here is, can I have the slides over? This session is all about biomarkers, that is PIMCA and diagnostic and surveillance of HCC. Hello. Yeah. I think before we begin with the topic, it will be a good opportunity to yes. People have to make it on the big screen, maybe. Yeah, I think before we begin with the biomarker subject, it will be nice to have a look as to how we see HCC in our clinics in our country over here. It is no doubt in the top 10, both as far as incidence is concerned and the mortality figures are concerned. And these are very pretty latest data till about 2024. But if you look at the landscape of HCC, I think there are two important changes which are taking place as we see HCC in our country. One, there has been an increase in the incidence rates of HCC in the country. As you can see from as we can see from here, with the increasing years, the number of the incidents is increasing, and this increase could be a real increase and could be a better diagnostics also, both of it. The mortality also is increasing. Despite all our advances that we have got, we still have a very significant mortality from HCC. And I think one reason for that is late diagnosis, because we get our patients very late in the natural course of the disease, and we are not able to offer them a curative treatment. And that's the reason why we couldn't make much of a difference in the mortality. And I think today's session is all about that how can we pick up HCC early by the better use of biomarkers so that we can make a difference in the survival. The other change which is taking place in the HCC landscape is the etiology. Right from our medical school days, when we were getting trained in gastroenterology, we always knew that hepatitis B is the commonest cause of HCC in the country. Hep B was the commonest cause of cirrhosis, chronic liver disease, and HCC. But today, as we see in multicentric trials, 2,600 patients, I think NAFLD, the fatty liver disease, or what we call as metabolic syndrome associated liver disease, is gradually become the highest cause, the top cause for liver cancer, followed by Hep B, and alcohol is interfering in each of these categories, a pure alcoholic disease or alcohol with hepatitis B or alcohol with hepatitis C. So I think these are very two important changes which are taking place in HCC. And whenever we talk of managing HCC, I think these two trends will become very important. The problem which is more concerning to us is the late diagnosis of HCC in our patients. And from this study, I have highlighted 4 important points which drive home the point that we are diagnosing it very late. If you look at the BCLC staging, I think majority of our patients from this 9 studies, they are coming at stage C, which is the intermediate stage. By this stage, you have already ruled out any curative treatment. Even though now we have become more flexible as far as we manage BLC treatment algorithms with lot of stage migrations, but still stage C means that for most of these patients the curative treatment is out. If you look at vascular invasion, almost a little less than half, one third to half of them, they have got evidence of vascular invasion, maybe microvascular also. If you look at metastasis, at least a third of patients have got metastasis. And what is the end result of all this? The curative treatment, even today, and this data is pretty recent, we are still offering to less than one fourth of our HCC patients. Coming over to surveillance, which is our topic today, if we try to answer three questions, why, who, and how, as far as surveillance of HCC is concerned, I think the first question is very easy to answer, why we need surveillance in patients with HCC. One is the reason that we have just discussed, that we need to pick up this cancer at a very early stage. So we need to have patients in our surveillance program so that we can pick up early in stage 0, stage A, very early, or an early stage where we can offer some uh, treatment. Does it have an impact on the survival? Now, this study very clearly shows that yes, proven positive impact on survival if you have a very robust and a strong surveillance program in your liver unit. While saying this, in this study, as you can see, that once the cases you have picked up are early, you are picking up more cases, and your survival and mortality, there is a difference in that in the subgroup of patients in whom HCC was caught during surveillance and in the subgroup of patients in whom they had reported with HCC without a surveillance program. So it is proven that surveillance has got improvement in survival. So HCV surveillance is associated with improved early detection, curative treatment, and overall survival. Now we come to the question, who? Who requires surveillance? Now, the essence of any surveillance program, I think, is twofold, that you need to have a very good diagnostic test, which will be sensitive enough with a good positive predictive value. But if you do it in the general population, obviously these parameters will go down. So you need to identify the patients who are at risk to make a very meaningful surveillance program. Now, based on the annual incidence of HCC for the different common causes of cirrhosis, these are the high-risk group which NASL has recommended that we should be taking up for surveillance. Cirrhosis of any etiology, especially child A and B, but of course in child C, those who are listed for liver transplant program. And in non-cirrhotics, and this will be a very important category for all of us, hepatitis B, we are aware, you can get HCC even without developing cirrhosis. So hepatitis B patients, ideally, all of them should be under any surveillance program. And that goes even when they are under treatment with their viral load negative, DNA negative, but they still have to be under a surveillance program. And in fact, theoretically, it is lifelong. Chronic HCV patient with increasing fibrosis, F3 fibrosis, they are also included. I am sure you're going to ask me the question that what about fatty liver disease? Why they are not included in this? Because we are aware that there are only two conditions in which liver cancer develops even without developing cirrhosis. That is, one is chronic hepatitis B, and the other is a fatty liver disease. But the problem comes up is logistical. That in India, with our population, with a prevalence of 30 to 52% fatty liver disease, and mind you, this prevalence is maybe just the tip of the iceberg. How do you screen so many patients? And you just have to have certain criteria whom to screen for fatty liver disease, for liver cancer periodically. So what we do right now is that yes, somebody with definitely persistently elevated enzymes, somebody who has got strong metabolic risk factors, including diabetes, hypertension, dyslipidemias, or somebody who is actually having a progressive fibrosis. I think we may still carve out a subgroup of fatty liver patients in whom surveillance is required. But so far, this is not made into the recommendations for general population, and that's only because of the numbers. The numbers are huge. The battery is running low. So now the question comes is, how do we do the surveillance? We have seen why is it important, because it's making a difference in survival. We have identified the high risk patients, and traditionally these are the tests which have been used to uh, highlight. There's a different regional guidelines who have done it. As you can see that most of the guidelines follow the twin combination of ultrasound with alpha fetoprotein. And in fact, in most of the centers, even today as we speak, we are all following that dictum of ultrasound with alpha fetoprotein. And here are the sensitivity, specificity, and sensitivity for early HCC, which is mentioned over here. And it stands to reason that if you combine, you get better yields rather than taking individual biomarkers for this. So traditional surveillance techniques, ultrasound and AFP profiling, have limited sensitivity for early stage HCC. If our intention of surveillance is to pick up the disease early, we require very strong biomarkers or a combination of biomarkers to pick them early to make a difference. And as you can see from this study, that a lot has to be done for this as far as predicting early is concerned. We need much, much better tests. So in India, if I talk from my experience, I feel the challenges which we have in a surveillance program, because any surveillance should actually have a good patient identification. We can have physician awareness, yes, needs to be increased. Appropriate test, we are still all fighting for it, and today's session is all about it. But I think the very important step in any surveillance program is appropriate curative therapy. What I mean is, if you have done an early surveillance at whatever level you are practicing, primary, secondary, or tertiary, but if you are not able to offer the complete treatment for HCC, then what is the use of this surveillance? We need capacity building for this at every level, because once you pick up, the responsibility is now of the clinician to actually offer something to the patient. Now, the patient requires for curative treatment, let's say resection or an ablative therapy. And if the facilities are not available with you, and only a very few centers have got this facility, then the entire exercise of doing a good surveillance actually is of no use. So I think capacity building in this case will come in a big way. It's a very what I've realized is that any good unit which is practicing surveillance, we do ultrasound and we do an alpha fetoprotein. Some innovations that have been done is that we have apps now which we are giving to the patients, and the app reminds them that 6 months time you have to come back for this, so that recall value, or you have a good department coordinator or a surveillance program coordinator who actually gives a call to the patient that you're due for this, so we don't miss out that our interval 6 months or 3 months or 1 year, whatever you have decided for this. One very often neglected area is the person who is doing the ultrasound, because USG is operator dependent. And it has been seen that if you have got a dedicated sonologist who has been working with your unit for many years and picking up the SOLs in the liver, as compared to like any diagnostic center where whoever is on call that day on ultrasound is actually doing the ultrasound for surveillance, there's a lot of difference on that. So if you are planning a good surveillance program in your unit, I think we should fight for getting a dedicated sonologist who is actually looking only for this, not only for days, for months and years, and well used to picking up even small lesions. So that small thing is going to make a lot of difference. Coming over to PIFCA, now we have been using in our unit PIFCA quite a lot of late, and I'll just give you quickly two cases. One, this was a very interesting case where a 38-year-old male with decompensated cirrhosis and HCV, and were treated for HCV with DAA of 24 weeks, had undergone TIPS because of refractory ascites. So that will become important when we interpret the image later. And he has been on a good surveillance program at our unit. Every 6 months, we have been doing ultrasound and alpha fetoprotein. Now, in August, he developed a lump in the lower back. And once he has developed a lump in the lower back, so we thought we went for it further evaluation. And we got an MR done, which showed an expansile mass, 3.5 centimeter. Mind you, we again repeated the AFP, which was normal. The ultrasound, he had just got it done recently. That also didn't pick up any space occupying lesion. We got a PET CT done thinking of a metastatic malignancy and let's find out where is the primary. And the PET CT had shown a very small lesion in the liver, which was less than 2 centimeters, around 1.5 centimeters. But we cannot call it as Lerite 5 because the washout was not very prominent, though there was arterial enhancement. So we were at a loss as to where is the primary and what to be done. And that's the first time PIFCA was done for this patient. And PIFCA had come very high, 1598. So after that, that biopsy which we took from the sacral mass, we put in IHC staining into that, and that showed hepatocellular carcinoma. So there's a very unusual presentation of a metastatic HCC where it was detected because of a sacral mass. And why our attention went to that is actually because of PIFCA, because his AFP and ultrasound by surveillance, they were as it is going normal. Similarly, in the second case, this is after post-treatment. Now, this is a case of decompensated cirrhosis NASH who had a small lesion and had undergone a microwave ablation in November, about 2 years back in 22. We kept him on follow-up as per our protocol, first after 3 months, then after 6 months. We noticed that there was a small lesion which was attributed to a residual lesion because of the heat effect, the ablation, and not exactly a recurrence. But the problem was, even though AFP remained normal, gradually over the last 6 months, we noticed that the PIFCA was rising. From 194, it reached up to 542. And finally, it became very clear that this was a 2 centimeter lesion, and we finally treated it with TACE. So, the main purpose of highlighting these two cases offhand was that yes, PIFCA has been useful to us, especially in situations where we had a strong suspicion of HCC, and but AFP was normal. And of course, you are all aware that AFP is now not exactly a diagnostic modality for HCC. In fact, it tells us about the tumor behavior and of course contraindication for transplant rather than as a diagnostic tool. We still bank on our imaging, and if required, we go for a tissue diagnosis for that. But these two cases highlight how we have been using PIFCA. What exactly is PIFCA? I think it's an abnormal protein. Basically, it's a protein induced by the absence of vitamin K or an antagonist present in that. You require a carboxylation, a prothrombin precursor. You require a carboxylation, and then it start producing the proteins. Now there is a defective carboxylation in this, and you get this PIFCA protein molecules. So which is very specific for HCC. Why I'm saying specific? This, I think this is a good meta-analysis of 38 studies involving over 11,000 patients, and you have got about 5,000 with HCC and a control equal number in control. And if you look at the pool diagnostic odds ratio, it's quite high if you compare both the groups. So PIFCA and its diagnostic utility for HCC, I think, is well established. If we combine two biomarkers, because it always stands to reason that if you take two sensitive markers, combine them, and let's see if you can improve. Yes, it has done. When we have combined AFP with PIFCA, I think your diagnostic odds ratio was much, much higher, as is depicted in this study, as compared to individually, both of them, either PIFCA or AFP. I think this study published in 2018, quite some time back, is the first study which directly compared 5 biomarkers, of which AFP, AFPL3, and PIFCA were the important subgroups. And even in this, if you see the area under the curve, I think PIFCA has done well both for liver cirrhosis, both for chronic hepatitis B, and it has actually outperformed AFP as per this direct comparison study. So if you look at the clinical practice guidelines, has FIFCA come into our surveillance or diagnostic methods? Well, INASL tells us about the tumor behavior that you can use anything as far as prognosis is concerned. But if you look at the first Asia Pacific consensus statement, which has been given out in 2023, it lists out very clearly a couple of conditions. One, I think it's important to read them out, that it is improves the detection of HCC. Second, detection of HCC in AFP negative HCC patients. Third, it predicts the microvascular invasion risk. Monitoring treatment outcomes and recurrence, like we did in our patient post ablation, this had helped us to pick up. And then, of course, clinically useful for indicating response to treatment. So, in all of this, if you look at the consensus agreement between the experts, I think PIFCA has scored very well as compared to other biomarkers. Coming over to GARD, frankly speaking, we have no experience on this. I'm being honest with it. We have not used this over here. And what we have been trying is the GALAD biomarker panel. But then again, we ran into a problem because we are not doing AFPL3 at all. So this actually study came very useful for us, that when it was compared, this is a pretty recent publication where it has been clearly shown that what is the utility of AFPL3, because in this particular randomized trial, the first part was developing the algorithm and the second part was clinical validation. It has been clearly shown that the clinical performance area under the curve of GARD was similar to GALAD across all disease stages, early and late. And so, what will be the use of AFPL3 in this? Suppose we even take this out and do only GARD, I think we will be getting equally good response. So, instead of going into a healthy competition with GALAD, I think this biomarker panel is going to be very useful to us. So finally, coming to an end, combining ultrasound with biomarkers, I think will be another step forward. For example, GARD uses both PIFCA and it uses AFP. And suppose we combine it with ultrasound also. And here is the study which clearly shows that it is performing much better than any of these individual modalities. If I talk of the future, I think we are currently working on this, that if we really want a very early diagnosis, I think liquid biopsy is the answer for that. And currently at our institute, we have started it for cholangiocarcinoma, where we are actually collecting bile and blood for all such patients with malignant hilar stricture. And we are doing the molecular analysis and trying to create a panel and see if we can come across or a couple of biomarkers which can help us in future, because it is a problem distinguishing a biliary stricture whether it's benign or malignant. So similarly, we can extend it to HCC also. That is the plan. And the second important part about liquid biopsy is how early you pick up, because the literature also says that you can pick up a tumor 12 months before it is actually visible on image if you're doing a liquid biopsies. So I think in future, but till we get onto that future, I think this is what Roche is offering us. We have all that. And finally, redefining HCC surveillance in India. This was a good paper which I had liked. And the conclusion was PIFCA AFP combination with or without an ultrasound, and development of a surveillance program must be accompanied by capacity building, the thing which I was discussing. That was the conclusion of the authors over here. This is the system which is going to give us the card essay, and I think people from Roche will be speaking more about this kit, whether it's available and how much is the cost. Key take-home messages will be: it's a very important to have a very strong, robust surveillance program if we want to make a difference in survival in HCC, because we are seeing the disease at very late stages. We need to pick up early. That's the bottom line. So whatever helps us to pick up the HCC early will be a huge, huge advancement as far as patient care with liver cancer is concerned. And of course, development of biomarkers is an ongoing process. Currently, I think PIFCA requires to be integrated more and more, because we have found in our unit that it's a very useful test to be done. And I'm sure with the biomarker panels coming up, the things are going to become much easier. Thank you so much for your patient hearing.
Thank you so much, sir. So there are a couple of real life cases that we have, and I would request Dr. Tawesak Tanwandee to just come up and share the same.
Yes, I just want to share the real world usings of GARD score in routine surveillance of the patient. Actually, not only the GARD score but also the GALA score. We just finished the prospective clinical trial for prospective surveillance of the patient at risk of developing SCC, comparing the ultrasound 105 1,500 cases versus the ultrasound plus GALA score. There is another score that combine AFP, PIPCA2, and L3. So what we saw is the use of GALA score can increase detection rate by 40%. So that means many patients go for further investigation because of abnormal biomarker. And the most of abnormalities of the biomarker that can pick up was the PIPCA2, is not the L3. So the PIPCA2 is among the maybe the among three biomarkers, PIPCA2 is among the most sensitive biomarker. When it comes to the GAD score, it's sometimes the marginal elevations of AP, the PIPCA2, then when it calculates combining with age and sex with it no cost, then you have separation between normal and abnormal, the GAD score. This one.
Yes.
So I just want to share with you some of the cases that can pick up for further investigation because of abnormal GAD score alone.
Yes, on.
Yeah.
Just
These are the patients that come to our clinic for regular follow-up. Okay. So this is the male 55, chronic hep C cirrhosis after SVR, including alcoholic. So during the regular follow-up with ultrasound plus AP, and then at that time we got the PIPCA2 available. So you see that AFP was normal, and actually the ultrasound was you can easily miss by using the ultrasound in this case. So we sent for a further investigation because of the abnormal PIPCA2. And actually, when you look at the GAD score was also abnormal. And the CT scan just show small HCC, just 1.1 centimeter, and this underwent treatment easily. Another case with 66 years old chronic hep C advanced fibrosis. Again, this patient, he got normal AP, but highly elevated PIPCA2. And when you look at the ultrasound, you see nothing but sky high elevation of PIPCA2 that bring us to the further investigation by the MR. So you see the lesion was in the caudate lobe, so it got to be missed by the ultrasound. So in this case, ultrasound was not perfectly normal. So this case just simply missed by the ultrasound and then picked up by the PIPCA tool. I just to show only two cases. This just for example why the biomarker, the PIPCA tool can pick up in routine screening of SCC.
Thank you so much, sir. And thank you, Dr. Bhaskar, for sharing us the real life clinical cases and how addition of PIFCA can help in HCC surveillance. I would now like to move on to the next chapter, but before that, just a quick reminder, if you could fill in the charts, and thank you to those who've already done it. It'll just take a couple of minutes, but it will add a lot of value in our understanding as well. Um we move on to the panel discussion, which will now be moderated by Dr. Ashish Kumar. We will be having our panelists, Dr. Tanwandee, Dr. Bhaskar Nandi. I would also like to call upon here Dr. Seema Bhargav, who's the chairperson and senior consultant, Department of Biochemistry, Sir Gangaram Hospital. Dr. Kaushal Madan, who is the director and head of Gastroenterology and Hepatology Department, Max Super Specialty Hospital, New Delhi, and Dr. Professor Ashok Ratan, who is the Senior Healthcare Advisor of Microbiology and Infectious Disease and a WHO advisor as well. We welcome you.
We have experts here, Dr. Seema, Dr. Ashok Ratan, Dr. Nandi, Dr. Kaushal, and Dr. Tanwandee. And we have already had a good discussion both on HCV duo as well as PIVCA. But here I would like to hear the opinion of the experts on this. So probably I'll begin with Dr. Seema, ma'am. She's head of biochemistry at our institute, Sir Gangaram Hospital. So, ma'am, so what do you see from a lab perspective? So, how feasible is HCV duo? Uh, what would be any challenges? What do you foresee? How feasible, like single day testing and then providing the results?
Thank you, Dr. Ashish. From a practical point of view, practical perspective, it's excellent for the patient because the patient comes once, the HCV duo test is done, it is the result is available within 1 or 2 hours, depending upon the lab, and the patient can go the very same day with or without treatment, but depending upon whatever the result is. Uh, uh, the only difficulty we might face is that that's a very subjective difference. Different institutes have different ways of having their tests done. So, like in some places, there is a common lab medicine, and in some places, we have highly skilled individualized labs. So, this is a gray area between biochemistry and microbiology, and I don't know how we're going to get over that. That's my challenge.
So, what Dr. Seema says that, for example, in our Gangaram Hospital, we have a separate microbiology department which does the HCV, HBV testing, HIV testing, and we have biochemistry which does the liver function test and some of these biomarkers like PIVCA and all. So, uh, so depending on the way we have this, so this could be one of the challenges also for having this kind of testing. Uh, I would ask Dr. Ashok Ratan, sir. So, in which population do you see that this would be a useful test, HCV duo test? For example, hemodialysis, immunocompromised, transplant setting, And and even in those who are blood donors, so what is your opinion on HCV2, on the patient population where we can use this?
See, this that is it working? No. This test is very useful, and I remember that for the last 6 years or 7 years, we've been in discussion with Abbott, who had the antigen test, but the cost was too much that it could not be offered. And since we had set up PathKind, which was a concern of mankind, I thought the first thing was to offer it to the surgeons, because surgeons are most exposed, and you know that 80% of infections are asymptomatic. Then I did read a paper by Anita Chakravarti from Maulana Azad, which was published in 2013. And I was surprised when I look at WHO's risk factors. Of course, if you look at CDC, CDC says that every citizen of America born after 1945 should and 1965 should get themselves tested once for hepatitis C. That is CDC's recommendation. Uh, Now you've seen that it's 0.1% or less than 1%. So that's not going to be feasible. In India, it has to be on high risk groups. And high risk, I thought the first thing was surgeons, because they don't know that they are exposed, and they don't know whether they are, because it's 80% is asymptomatic, and we had treatment available. As long as treatment was not available, I was not interested. But once a directly acting antiviral became available, then I thought this is one area that we must give. And since we were mankind and pathkind together, that was the target group I wanted to do. Then I saw Anita Chakravarti's paper, and in that she says that in the world you will find, they would say, IV drug abusers. That's number one. Then, since blood transfusion has been taken care of, then the other ones are less than, that is 60 to 70% is IV drug abusers, and the rest of them are all in 2%, 3%, 4%. In India, the commonest is blood transfusion. If you have had repeated blood transfusion, you're more likely to have HCV. So that's one. Second one was dentist. Third one was any medical procedure done. Fourth one was tattooing. And IV drug abusers are okay if you are working in Punjab or early on in Nagaland or Manipur. But other places, you normally don't get drug abusers. So I think wherever, so I would have not, I would have suggested that all medical persons, everybody coming to the hospital, working in the hospital, must know their HCV status. Then you have others who have exposure. I remember in Meerut or thereabout, there's a village where nearly everybody is HCV, and that's partly because of our quacks and our villagers asking for treatment by injection. They are satisfied only with injections, and so I guess we need to focus on high risk group. And if you do both antibody and antigen together and you link them to treatment, there's no point, no test should be done unless it's linked to cure, unless it's linked to treatment. So there's no point in finding out that a person is infected and not have the wherewithal to give the treatment available. But since Glylid has given this available to us as generic drug, though it's not off patent yet, is generic drug, it's available, treatment is for 3 months. So I think all the persons associated with high risk group must be tested.
Yeah, thank you. And you raised a very important point regarding the healthcare personnel, especially surgeons, dentists. We all of us, we are constantly exposed. And I think HCV Duo would be a better test than rather than getting an anti-HCV test done. And we recently have initiated at Gangaram, initiated a health checkup for all the healthcare personnel. And I think if, this so this test would have been very good, but I would request Roche personnel to include it in our Gangaram hospital as well. So next question, switching gear from HCV to HCC. So my next question is to Dr. Kaushal. We have been seeing lots of HCC patients in mast celled population, fatty liver population. So there have been varying etiology. Earlier, HCC was mainly with patients with hepatitis B and C. But now, lately, even with non-cirrhotic population of mast cell, we are seeing lots of HCC cases. And so, since what is your experience in using PIVCA, and did you have ever used GAD score, and especially across all these etiologies, B, C, alcohol, and do you see any benefit?
So I think I completely agree with you that the HCC related to MASLD, even alcoholic liver disease has been rising. B, we have seen it is coming down. C, somehow now we are seeing the patients whom we had treated, say 8, 10 years back, who had hepatitis C and cirrhosis to begin with. Now they have cleared the viremia, but now coming back with HCC. So that's the third major group. Second issue was uh, initial screening we usually do with AFP and ultrasound. I agree. For the initial screening, we are not using PIVCA2. It adds to the cost. Maybe after this, we might start using it. Maybe once we have more data. But once we've picked up an HCC or in a high risk group where we are suspecting that patient might be having a lesion and AFP is normal, we definitely do a PIVCA2. And once the patient has been diagnosed with HCC, we do both AFP and PIVCA2 and do it serially as the patient is being followed up for treatment. GAD, yes, I would agree. We've not started using it up till now.
So you are means you have been using not for the diagnosis or surveillance,
Not
but
for
for
initial surveillance.
purely for the patients
so-
on follow-up.
Yeah.
You do both the markers and
So
then
as per the guidelines, alpha fetoprotein and ultrasound every 6 monthly, but not using PIVCA2 in that surveillance protocol, but out of protocol in all other cases once they have been diagnosed with HCC or at a very high risk and AFP is not helping.
okay, thank you.
One question,
Yeah.
if I may, I'm sorry. So what I don't understand is that PIVCA has been in the market for a long time, for several years, about 4, 5, 6 years at least, if not almost a decade. And all these guidelines, all the international guidelines have come up after that. Also, they have their latest guidelines are 24 and 23, I think. Yet, the only guideline that includes PIVCA is the Japanese guideline. Why is that? Why are all the other guidelines not including it? And I think that is what makes clinicians not use it.
I think, yeah.
Maybe I can
Yeah,
answer
yeah,
that.
please.
Then when I was medical student and a young staff, that was 40 years ago, when I was the PIPCAR, those days was produced by ASI and it was ELISA based. So I did ELISA by myself and try to look at it. So it's not popular because it's just locally in Japan until Weiko Fujifilm acquired all of these tests all together and try to develop using the proprietary machine and then and also the L3 those days when I was young staff I did vertical gel electrophoresis with that from Waco company. So then they combine all of these things together into 3, and then that made useful, and then originally adapted by the Japanese.
Right.
That was in the early 80s.
Right. So I'll just add to that. In Japan, all these three markers, in fact, not only PIVKA2, but AFP, AFPL3, and PIVKA2, they are being covered by their insurance. So I think, and insurance covers it every 3 monthly, not even 6 monthly. So although they have it in guidelines for 6 months, so patient doesn't have to pay. And when PIVKA was introduced in India, it was a really expensive test. So I think in fact most other countries also. So that's why it did not come into practice as a surveillance strategy, but as an individual patient, you may still do PIVKA for an individual patient. Can I also ask a question since you are a moderator? But so question to Dr. Tanwandee. Sir, initially when PIVKA came, even now the reports we get are in milli AU per ml, Anson units per ml. But I think the Alexis gives it in nanogram per ml. So how does that correlate?
Not convertible. So the for the uh, you know before the GAL score, they have the GALA score that is originated by Philip Johnson from the UK. So that he invented the GALA score, and then come to the GAL score where we did the analysis of the cohort, and then see no difference in terms of sensitivity of detection among different etiology of HCC, but the way of measuring the PIPCA2 is not the same between the Alexis PIPCA and the Wacom Fujifilm PIPCA. So and they the Fujifilm they use AU. A stands for arbitrary, so it's nothing, just arbitrary unit. So it's not validated. It just that terms.
Actually, while reviewing the literature for PIFCA, ma'am, the questions that you had asked, the same question was there, that as to why it is not in regular use, especially in the guidelines. So what what I could understand was that in science, there are many molecules which have been invented, then forgotten, and then rediscovered. So actually, PIFCA comes into that. That suddenly you realize that when you are looking for some better markers, then somebody realized that why not have a look at this old one, which was already there with us for quite some time. But even if it's not in the guidelines, I'm sure all the panelists will agree that in most of the transplant centers, PIFCA is used in almost all the cases where this HCC is there.
And one reason for not having in our Indian guidelines, because we did not have experience with PIVCA initially. But now even at Gangaram, we have now about 1,000 patients where PIVCA is done, and we are analyzing the data. And let's see. One thing, recently we did a brief analysis, interim analysis, which showed that our cutoffs are a bit higher than what the international suggests. Maybe due to some different some reason the cutoffs did not match with the international, and we have this experience, maybe we all have, because the international cutoffs are about 40 IU, but what we experienced in our setting, patients who do not have HCC versus those who have HCC, the cutoff for differentiating between HCC was about higher, about 100 or so. But we would need more data, and then we could analyze.
I think vitamin K, if we look at, is more ubiquitous in our Indian diet.
Yeah.
So getting a deficiency like action against vitamin K is difficult in us.
Yeah.
Your levels are maybe higher.
So
But
that
totally
we did discuss,
there is no
probably vitamin K deficiency or malnutrition may play some role in having higher cutoff. But still, if we are able to define our own cutoffs, but PIVCA will remain a good test for these patients. So
that is also one of the reasons, since we do not have a cutoff for our Indian population or HCC, we've not been using it for surveillance. But once you have an HCC and you have a baseline value, and then you can follow it up serially.
Yeah. So even I've seen many patients in who we have given therapies like TACE, STAIR, or immunotherapy, and we follow with these PIVCA, and we are able to pick up early recurrence in these patients. Okay, so coming to the next question is probably to Dr. Tanwandee. What has been your experience in using HCV Duo in initiating the treatment? How confident would you be?
I think in my hospital we replace anti-CV with dual. So once you order anti-CV, you're gonna get Hep C dual. So once dual antigen part positive, then you are eligible for the treatment. One example that I just shared the experience with you about patient with hemodialysis, where we got Hep C dual antigen positive and then go for the treatment. But in this particular patient, you cannot see elevation of the enzyme, especially in the patient with chronic renal failure. The enzyme, the ACLT, got to be quite low. So that can be detected by the abnormal and seroconversion by detecting antigen during periodic follow-up. Because usually in the patient on waiting list for kidney transplantation, we got to repeat anti-CV testing every year. So to see whether there is any new infection. So in this particular case, they got called antigen positive and then got treated.
Okay. And the next question also, I would ask you, Dr. Tanwandee, about the GAD algorithm, since you must have been using for a long time now. So what is your experience with using GAD algorithm, and have you used GALAD? And is there any point in doing GALAD where we have to include AFPL3 for the... So what's your experience for GAD versus GALAD?
Actually, I started with GALA score first by the prospective study, 3,000 cases for over a year. So the criteria of excluding HCC going to be negative ultrasound at 18 months after the follow-up. So in the patient with ultrasound, we got 1% of HCC development. In the patient, in the groups of ultrasound plus GALA score, we got 2.6% HCC, and about 40% of these patients detected by abnormal GALA score alone, no ultrasound abnormality. And actually, when you look at the recent study from Emisigo groups and the group from Houston, you see that the positivities of these biomarker can be positive more than a year after ultrasound detection. And there is no reason why the groups of ultrasound plus GALA score will have higher incidence if we randomize both group equally. So that is just we detect earlier with the biomarker. And then now we're going to start the prospective study comparing the GAS score plus GAS score and ultrasound prospectively for 3,000 cases in high-risk group for 3 years. 1 year is not enough. So we got to start later this year for 3 years to see how effective is the prospective surveillance, because most of the study nowadays is just cohort that report the sensitivity and specificity of the test, but in terms of surveillance, the sensitivity and specificity got to be lower as compared with the cohort so that study. But I think I share with you some cases. I think many of our cases detected by abnormal PIPCA alone.
So, Dr. Kaushal, what's your experience? Like you mentioned that you usually perform AFP PIVCA after treatment. So, what do you do when you have high PIVCA in the follow-up of these HCC patients after treatment, but the ultrasound is negative? So, how do you follow? Or how do you manage these cases?
So if AFP is normal, ultrasound is normal, but PIVCA is high. That's what you mean. So obviously, I think my next go-to test would be a cross-sectional imaging, triple phase imaging, either a CT or an MRI. And many times we end up or doing both of them, because you first do CT and then do MRI. Sometimes the MRI is able to pick up a lesion, and we've had cases where the other way around, AFP is rising and we are not finding any lesion, and ultimately that lesion gets picked up 6 months down the line after 3 series of imaging and maybe involving a PET. That happens when you are looking for a very early HCC which has just started producing AFP but not visualized on imaging.
So does that mean that you are using PIVCA regularly for patients along with AFP and ultrasound after they are diagnosed and when they're on treatment?
On treatment, yes.
On
Now we are
treatment.
regularly using both.
I think the most difficult part got to be the patient after the treatment with abnormal PIP count or still rising of the PIP count, but the MRI or CT did did not find any abnormality. Even we try to look everywhere, there is no lesion, but the PIP count still keep rising. That is the problem. I think I found a few of them. Eventually, they're gonna have liver lesion detected, mainly diffuse HCC. This could be easily missed by most of the imaging.
Dr. Nandi, you want to add something?
We do two things in the situation that you have given. One is, of course, cross-sectional dynamic imaging, either CT or MRI or both. And the second thing we do is we also reduce the interval of surveillance if we don't find anything in positive. So let's say instead of 6 months or 3 months, we can even do it even monthly, depending on the suspicion. So these are the two things we do if the PIFCA is rising, but we are not able to pick up anything on imaging. And at our center also, we are doing PIFCA in all cases who are on treatment or post-treatment.
Can I just say?
Yeah.
What Dr. Tanwandee said, he just said that PIVCA keeps rising and they do not see any lesion on imaging. What I would like to remind everyone here is that biomarkers are the first to be released by abnormal cells. A single cell that is abnormal can release the biomarker. You are not going to find a lesion at that single cellular level. So please understand that if the marker is raised, you must do something about it. I know I'm talking like a biochemist and not a clinician, but that's what it is.
No, you are absolutely right, ma'am. Dr. Ashok, I would like to ask you, since you are also associated with WHO and then WHO's goal of eliminating HCV. So do you see a role of this test in India's road to hepatitis elimination, HCV duo?
I think there is Dr. Sareen had already mentioned that we are not going to eradicate hepatitis by 2030. That's not going to happen. So he had said that maybe by 2070 we would be in a position. So I guess I mean India has many priorities, and this is something that needs to be done. But I think we need to do it. We need to put it in the logical place, and we must make our healthcare workers safe first, then attend to the high risk persons, and then only I think everything will be covered. So it's not going to be possible.
Yeah, it's not going to be easy. Yeah.
But with 10% of the HCV population residing in our country, which is about 1/100th of the rest of the world, don't you think that we need to be more active about it? Whoever would like to answer that.
Yeah. Anyone?
Oh, I think priority is for tuberculosis. We promised the world that by 2025 we would be able to we would stop tuberculosis as a public health problem. That means that we will be 10 per 100,000 population. We are 700 in Delhi and 350 per 100,000 population in rest of the world, rest of India. We started with 209 or something. So we started detecting more rather than eradicating tuberculosis. So we could act together for COVID. I can't understand why the same kind of mobilization cannot be taken place.
There is one more change in the perspective of tuberculosis. Earlier, it was considered a disease of the lower middle class or the lower class socioeconomic status, while as now it is found in the most affluent people also. And I don't know how. Maybe Dr. Ratan, you could answer how has it changed?
I think more diagnosis, but of course, I remember when I was still in AIMS, we'd done something from the Rashtrapati Bhavan side. So it's not, it was say 20 years back. So it's not that it's thought to be, of course, slums persons will have much more, but uh, as you know, one bacteria can cause disease. Three bacteria can cause disease. So three bacteria we will inhale. If I'm a singer and I was singing now, each one of you will be infected. So uh, if the president or prime minister was there, he or she would also get infected. So I don't know how we got the concept. Maybe it was hidden for some time. Maybe it was kept under wraps, and now diagnosis has become clearer. So we have realized it, but it affects all parts of the body, all parts. And I think many VVIPs have died as a consequence of tuberculosis before treatment was available.
So what you had raised, I'll just comment on this. The question that you have raised is why, we are not able to hit the targets. If we look into public health policy, I think sometimes it becomes skewed because of the reliance on numbers. We always rely on how many cases, how many deaths, and all that. You look at hepatitis B, I think you can count on your fingers the number of preventable cancers. comes under them. It's a preventable cancer over there. But it took us so many years to at least introduce it in the immunization program. And after introducing Hep B vaccine immunization, even today, I think the penetration is less than 30%, one third, where we are getting it.
Where they made it.
I think, especially in medical profession, I don't know why. So I think in public health, the priorities become a bit different. But if you look at the gravity of the situation that you have, that way hepatitis B should have been way high up. Because the amount of morbidity it causes, commonest cause of chronic liver disease, commonest cause of cirrhosis, commonest cause of cancer, let's say, till a few years back.
So we have achieved certain things, but it's a long way to go in elimination of hepatitis.
But I think with the availability or with the now the National Viral Hepatitis Control Program, I think if this is incorporated into that, since we have it running, but I know it's not going the way it should have gone. It came up with a bang, but I think thereafter fizzled out because people realized that there is no more hepatitis C as a clinicians, but as a public health issue, it is still there in the community.
So for public
Ashish,
health perspective,
when
I think cost is important thing. So maybe Roche can think about it to bring down the cost further.
Ashish, when I was in the army and when we joined it, I saw the generals were very fond of asking us to give us a vision which was 20 years or 10 years down the line. Later, I realized that most of them would have been retired by the time that vision would have come. So, what sir is saying about 2070, we will not be here to see that. So, it's a very safe target to fix, By 2070, we are going to eliminate it.
So are there any questions from the audience? Like here are experts to answer.
While someone is thinking of a question, may I make one comment?
Yeah, sure.
Um, uh, I think this is very, very appreciable of Roche to actually develop an assay that is for AFP-L3 and then to say that no, the use of it is not beneficial. I don't know of any company that does that undermines its own R&D. It's not actually undermining, but you're actually negating all the money that you have probably spent in that R&D and developing the test and then doing all these studies for GALAD and GAD score. I think it's quite appreciable.
So And we also recently had a guideline meeting. Dr. Tanwandee was part of it on GAD score. We would have hope to see that published within a couple of months now. So, any questions from the audience? And then probably we are standing between you and the dinner.
Just to add comment on deleting the L3, because given my study using the GALA score, most of the abnormal GALA score was the abnormal PIPGA2, it's not the L3. So 80% of abnormal GALA score was part of abnormal PIPGA2. It's not the L3. So that was the only prospective study.
So it's not a question really. So I agree with Dr. Seema that the biomarkers are the first things which we can look into for any kind of disease. Of course, I'm not very this thing about PIPCA2. I mean, similarly, like Dr. Nandi said, that molecules had come, were evaluated, but there was not sufficient probably focus at that point in time. So one of them that we are evaluating at this point of time is a biomarker called SUPAR, soluble urokinase plasminogen activator receptor. Now, this appears to be a very good predictor of mortality. In case of sepsis, if the values are more than 6, then the patient must be admitted, and the chance of that person going into frank sepsis is much higher, and mortality. It is also seen that in other diseases, that includes hepatic diseases, kidney diseases, pre-diabetes. This is probably a very good marker to give certain idea. And very interestingly, 8-9 years back, if the first evaluation was done at Sir Gangaram Hospital, and a paper was published, but then it went into hibernation. It has come back again. I'm doing a evaluation along with RR Hospital and ICMR. So let us see. So that's
I'd
how it
just like to
happens.
make a small comment on that. So we did do a prospective study. We had actually two studies. One was on procalcitonin, and the other one was on SUPAR. And then we did both of them together also. So in procalcitonin, we were able to find a different cutoff for the Indian population. Not only did it tell you when sepsis was occurring, it also differentiated between culture negative and culture positive sepsis. That was at, I think, at 1.46 nanograms, and frank sepsis was at 3 or 4, I don't remember. Then when we compared SUPAR and PCT, there was no added benefit that SUPAR gave, because mortality was very clearly predicted by procalcitonin also. And then finally, because SUPAR is so difficult to procure and was so much more costly, we continued with procalcitonin clinically. Studies, I'm sure, is something
Yes,
different.
I agree with you. So because the focus was completely, SUPAR's focus was completely on sepsis, that how it was corroborating with the other markers of sepsis, say HSCRP or PCT and things like that. But now it appears that it is a holistic biomarker for a number of illnesses, including autoimmune disorders, hepatic disorders, various kinds of cancers. So the it has become much broader, and now it has become easier to procure also. The Danish company which produces it is now, we are in the process of getting a CDSCO licensing for
That'd
that.
be great, but I wonder what its specificity would be then, if it
No,
is
there is no
sensitive in so many
so
things.
yeah, that's a very major issue. But then now that government has gone into too much with the wellness program, I think maybe this may be introduced as a wellness marker at certain point in time.
Yeah. I think we had a wonderful discussion on both these biomarkers, HCV Duo as well as PIVCA. And I would like to thank Roche for initiating this discussion, and I would request them to have more of such meetings, and so that we all spread the awareness. Like we mentioned, that awareness is one thing which is most important in eliminating all these risks. So I would thank each of the panelists, Dr. Ashok, Dr. Nandi, Dr. Kaushal, Dr. Seema, ma'am, and Dr. Tanwandee for sharing their experiences. And with this, I would like to close the session here. Thank you.
Sure. Thank you so much. Thank you. Thank you so much for explaining. Thanks, Yashi. Yeah, you're.
Thank you very much. Thank you very much to the panelists. So big thank you to everyone for listening, for participating in this exchange. My name is Karan Kampani. I am the Asia Pacific lead for infectious disease for Roche Diagnostics, based in Singapore. I have to say a big thank you for all the energy and the discussion that was happening over here, right? On behalf of the Roche Diagnostics team, there was a great exchange over here. And I think I was trying to see how to summarize this session, right? And for me, it came out as 3 E's came out. The first was talking about early detection. There was a lot of detection discussion from Dr. Tanwandee, from Dr. Ashish, about how many people are living with HCV, right? There's 5.5 million in India alone that still have HCV, and only about 30% are getting treated. That's a lot of people that we're missing right now. And with HCV Duo, we have one more tool with already what we have in terms of detecting these missing millions. The dual antibody antigen test is superior in the sense that it can catch things early. For 3 weeks, there was a lot of good discussion on this as well. And it can enable the same day diagnosis and treatment, right? This is the key, how with a treatment available, we heard, how do we treat all the people? So we find the people, but we also treat them. There was a good point made about why test someone if there's no treatment available. And in this case, it's curable. So let's find the missing millions and treat them. A lot of discussion on high-risk populations as well. We heard about hemodialysis, I heard about blood banks, about surgical operations as well. With all of these, we now have a critical tool in India. So hopefully, as Dr. Ashish said, it's not only about discussion and awareness. I think that's the first step, but hopefully we move to some action as well. Second, in terms of detecting HCC at an early stage, we talked about PIFCA as a biomarker. PIFCA2 is a very liver-specific biomarker, and its higher sensitivity is very, very important in catching things early. It also reduces the variability that we have seen in some of the cases shared in detection of early stage HCC. And the last was the GAD algorithm, right? We're still in the early stages in India, but we know from Japan, from Taiwan, from many other countries where it's already part of surveillance programs and it's being used. So hopefully we can start using the GAD score, which is a combination of gender, age, also AFP and PIFCA together, more actively in India. So the first E for me was really early detection. The second was a lot of expertise, a lot of clinical expertise, a lot of medical expertise and excellence. Thank you for sharing the evidence. There was clear data that was shown from studies for HCV Duo, for example, from South Africa, from France, from Japan, from Thailand, that we can now leverage and also use in India. The same for the clinical cases that were shared for PIFCA. It's great to see what is happening with ultrasound and the combination of AFP and PIFCA together, also with your experiences in the past and how you've used them. So thank you again for the scientific rigor. Doctor, you mentioned that we've developed something from Roche and the data did not look good and we don't use it. And we stick by this. If the data looks good, we really want people to know that there is value out there and use it. But if it doesn't look good, we also are willing to say, yes, in R&D, we take these moonshots or try things out. And if it doesn't work, we also are brave enough to say, don't use it. There are other tools. So please use the things that are useful. We have a lot of tools out there. Please use them. And that's the key point of this. And the last is really energy. The last E was energy and enthusiasm, because I could see that we could go on for another half an hour. There was no stopping you, right? I think there was one moderator, Dr. Ashish, but there were many other moderators as well asking questions, and it was a good discussion. So I think this is a very good sign. I walk away very enthused that even in Sagangaram, that's the fourth E. And I really hope that there was this discussion about microbiology lab and biochemistry lab and not being able to do the test. I think after this, with all this enthusiasm, I hope we can make sure that you sit together and figure out how we can start the testing in Sagangaram as well. But no, jokes aside, a big thank you to first all the speakers and panelists. Dr. Tanwandee, thank you for sharing your expertise. Thanks a lot. Dr. Ashish, the same thank you for sharing your expertise. And Dr. Bhaskar, thank you for sharing your experience and expertise, and also the panelists, Dr. Bhargav and Dr. Madan. Thank you very much for sharing your thoughts, your expertise, and hopefully we can, with all this enthusiasm, with all this energy, really put these biomarkers and the innovation we have into clinical practice. So on behalf of the Roche team, thank you very much for being here. And if I can invite everyone to just come here for one group photo, and then we will head for dinner. Thank you. Somewhat is it actually. So every speech bounces on the student. Some people cannot stand on it. Come.